Hello, my name is Abraham Hulst. I'm an anesthesiologist at the Amsterdam UMC, and I'd like to discuss the perioperative management of patients using SGLT2 inhibitors. What we need to discuss is why these are advised currently to be stopped, and why I think we should maybe reconsider this, and if we were to do so, how we could do this safely. So for those less familiar, I'd like to quickly summarize what we are really talking about here. So SGLT2 inhibitors are sodium glucose transport 2 inhibitors. They're recognized by the suffix gliflozins. So, and the most commonly used ones are DAPA, EMPA, or canagliflozin. So who cares? I think almost everyone by now. This is the cause of a number of prescriptions and a very clearly increasing trend. This is England, but in the last couple of years, I think most clinicians will notice that the number of patients using this type of medication is increasing very rapidly. And for good reason. This was introduced as a management for patients with type 2 diabetes, but clinical trials found out this was not only good for glucose control, but improved patients' course of heart failure, kidney failure, and by now we know that also patients without type 2 diabetes and either cardiac or renal disease benefit from this treatment, and therefore the number of patients using this medication is increasing rapidly, and people are being helped very effectively. So what does it do? The inhibition of SGLT2 causes glucose loss by the kidneys. This lowers glycemia, and this improves glucose control. This was the intended sort of initial mechanism, but it turned out there's different cardiorenal protective effects that I'll go into a bit more, but that are now the indication for all these other forms of disease that or reasons why people are being treated with this kind of medication. So why do we stop SGLT2 inhibitors before surgery? This happens, I think, in most hospitals, and this is because of the fear for SGLT2 associated perioperative ketoacidosis or euglycemic ketoacidosis. This was reported shortly after introduction of this medication, and the number of reports increased quite rapidly over the first couple of years. And this led the College of Cardiology, the FDA, and different scientific societies to come out with an advice to stop any SGLT2 inhibitor 3 to 4 days prior to surgery to prevent the risk of metabolic acidosis due to ketogenesis. So how does this work? SGLT2 inhibitors, as I said, act on the kidneys. They induce glucose loss, and if this is in chronic treatment, glucose is lowered. This has an effect on the pancreas. This is slightly oversimplified, and the mechanism are not completely understood, but for purpose of this presentation, I think it works well enough that the glycemic effects on the pancreas cause a lowering of insulin levels, an increase in glucagon, and a change in sensitivity to insulin, and a change in insulin-glucagon ratios that make patients more prone to ketogenesis through a increase in lipolysis, a change in insulin-glucagon ratios, and these act on different tissues, but primarily on the liver, by making the threshold or the stimulus for ketogenesis to increase, whereas the natriuresis in the kidneys also increase their ketone reabsorption, and together making the likelihood of ketonemia or the level of ketonemia slightly increased. And this is a well-studied effect, and there's a moderate increase within physiological levels of ketone bodies in the blood in all patients using SGLT2 inhibitors. Importantly, and why I sort of wanted to show this overview, is that this process can also be treated by giving glucose and insulin, because if we supplement glucose or carbohydrates and give some insulin, this pathway is inhibited, and insulin is a very effective suppressor of ketogenesis and therefore can prevent ketonemia. So these case reports that have come out, of which they've come out a lot, are a little bit troublesome in my opinion, is in the sense that they're not very complete. So it's hard to judge whether the SGLT2 inhibitor is the main and only cause of the postoperative ketoacidosis in some instances. So, as we all know, there's very often a form of respiratory acidosis. There's all other types of metabolic acidosis. So, hyperchloremic, lactate acidosis. And very often in these case reports, if you read them carefully, these were not even mentioned, or, they found a form of acidosis and they found ketones, and they're in a patient that was using SGLT2 inhibitors. And these are, and people were acutely aware after introduction of this type of medication. So a lot of cases were sort of indicated or diagnosed as SGLT2 related ketoacidosis. And one problem that not many people are aware of, or that not been extensively researched, is that there is a form of ketogenesis present in perioperative patients anyways. So fasting, surgical stress, post-surgery makes you prone to some level of ketonemia after surgery anyway. And if you then only measure patients that use an SGLT2 inhibitor, you might sort of falsely identify these as SGLT2 induced ketoacidosis. So we looked into ketone levels during cardiac surgery, and interestingly we found that preoperatively these were commonly very low. The threshold for clinical ketoacidosis is a ketone measurement above 3 millimoles per liter. But even before cardiopulmonary bypass, but especially after in patients with cardiac surgery, you saw a very significant increase in almost all patients. This is not to pathological levels, but just to show that there is an increase in ketone levels in many patients, and that's still present in ICU. So patients with type 2 diabetes and SGLT2 inhibitors have this to sort of the same extent, or a slightly more at some time points. And patients that don't have type 2 diabetes were using an SGLT2 inhibitor for some reason kind of seem to have a similar profile. So and patients with type 2 diabetes and SGLT2 inhibitors did not significantly differ from these previous groups, showing that the rise in ketones maybe is due to, in a large extent, due to surgery, fasting, patient factors, and not in all cases the SGLT2 inhibitor is a big contributor to this effect. So therefore we have to be slightly careful in diagnosing these patients. What we also could learn from these case reports is that treatment with glucose and insulin seems to be effective in suppressing ketogenesis and bringing back down ketone levels to normal values and correcting metabolic acidosis. And the outcomes of most of these case reports seem to be mostly benign. Some had a prolonged stay in ICU or in hospital to correct acid-base balance, but in most cases not by long, and in many cases nothing else really impactful was reported. So this is not to say that this doesn't exist, like SGLT2 inhibitors can cause ketoacidosis, and in some cases it can be significant and impactful and should be recognized and should be treated. But it is one problem that we should weigh against other problems. So as I said, we should be aware of this. We should monitor for metabolic acidosis. I think that's the most important thing. And if you suspect an SGLT2 inhibitor associated ketoacidosis, you should measure ketones either through a point of care test or through the lab. And I think if you diagnose a case, you should treat with glucose and insulin or carbohydrates through oral diet. Or you could prevent these if you think the risk is high by administering or like doing appropriate glucose control with insulin perioperatively. So why do I think we should think about, or why maybe this practice could change in a couple with time, is that there might be good reasons to actually continue these SGLT2 inhibitors during surgery. And this has a lot to do, I think, with the primary indications for this medication. So why has this type of drug been so successful? We've got large long-term clinical trials with thousands of patients that showing, for instance, in patients with chronic kidney disease, that progression of renal failure is lower in patients being treated with egliflozin, and even mortality rates are lower. This is for chronic kidney disease. Same for heart failure. Hospitalization rates are lower. Cardiovascular related mortality is lower. And this has been trialed for all different forms of SGLT2 inhibitors and seems to be a class effect and a very robust finding through a lot of very large long-term outcome randomized trials. Interestingly, I think a little over a year ago, there was a similar trial for heart failure that was followed up by a stopping study. So there, both the placebo and the SGLT2 inhibitor were stopped, still blinded to the researchers and the patients, and they followed up. And you see that the rate of heart failure hospitalization quite quickly corrects to pre-treatment levels. So sort of the disease level goes down with SGLT2 inhibitor treatment, but 30 days after withdrawal, this sort of goes back to baseline. And same with questionnaires related to like cardiovascular health, go back to or like towards pre-treatment levels, and the groups combine again. And this is already after 30 days of withdrawal. So there seems to be quite an acute, quick effect with treatment, but also with withdrawal. And I think 30 days is not the same as 3 days, but at least we see that there's quite a quick reaction to either starting or withdrawal of treatment. But there's also other, I think, perioperatively relevant complications that have not been so far subject of large randomized trials, but were evaluated in post-hoc analysis. So, for instance, atrial fibrillation seems to have a lower incidence in patients treated with SGLT2 inhibitors, and in meta-analysis there seems to be significantly lower rates in treated patients. And a particular interest of mine is acute kidney injury. In similar analysis of large randomized trials during follow-up, the incidence of AKI seems to be lower, and this is something we are trying to do in prospective randomized controlled trial to confirm these findings. We've done one study in cardiac surgery. We followed up with a second that's nearly complete, because cardiac surgery is post-operatively the highest indication of of acute kidney injury. We do anesthesia, cardiopulmonary bypass, lowering blood pressure, cardiac output, causing vasoconstriction, and all other types of inflammation, tissue injury that affect the kidneys. Ischemia, reperfusion injury, lower perfusion, reductions in GFR have all been described. These are a lot of mechanisms, but they're sort of trying to explain how they all combine into the problem of cardiac surgery associated kidney injury, but also sort of highlighting the pathways that could be influenced by SGLT2 inhibitors. So correcting hyperglycemia, like increasing ketogenesis, is actually described as a pathway positively affecting oxidative stress. Natriuresis and the intrarenal feedback can positively affect intrarenal regulation and stimulate GFR, and the lowering of a highly metabolic demanding process of reabsorption of both glucose and sodium reduces workload, decreases the risk of hypoxia, and therefore the risk of acute kidney injury. These are some of the presumed pathways or beneficial effects. And in a small pilot trial, we actually found that the risk of AKI post-operatively was lower. And in addition, we also measured ketones, and we found similar effects to the slide I showed you on cardiac surgery ketone levels, in that both groups have an increase during surgery in ketone levels. However, these did not differ significantly for patients receiving an SGLT2 inhibitor. So the additive effect of this treatment didn't seem to affect ketone levels that much. We're trying to confirm these findings in a large randomized trial, including nearly 800 patients in 7 cardiac surgery centers in the Netherlands. And we're expecting these results fairly soon, later this year, and maybe adding to the evidence and the arguments to actually start or continue SGLT2 inhibitors perioperatively. So I think we have to weigh risks and benefits, and these at the moment have to be on sort of an individual level, but there are things to consider. So you could think about the cardiac benefits and the risk of going into or like aggravating heart failure or worsening heart failure preoperatively and postoperatively in sensitive patients. But like potentially or hopefully in the next couple of years we'll know more about the risk of new atrial fibrillation and whether SGLT2 can effectively protect from this. Worsening renal failure in chronic kidney disease or new acute kidney injury could be an effect that is positively influenced by SGLT2 inhibitors. And the glucose control effects are also to be considered. Whereas on the other side, there is a risk of SGLT2 inhibitor associated ketoacidosis. However, this is rare in patients that don't have diabetes. Therefore, This risk-benefit analysis could be different in patients that are treated for an indication of heart failure compared to patients that have diabetes. That will also influence the risk of their likelihood of getting a ketoacidosis, I think, and therefore the risk-benefit analysis might be different. Also, there's sort of, if you want to prevent this, I think there's two valid options. You can either take away the SGLT2 inhibitor or potentially just as effectively suppress ketogenesis through treatment with glucose and insulin. Importantly, the evidence of benefits are variable. There's different mechanisms, there's different benefits, but they're a bit circumstantial. There's no large randomized trial showing that we should definitely do this. There's no randomized trial that compared preoperative stopping of SGLT2 inhibitors to continuation. So it's too early to change guidelines. But I think on an individual level, it's possible to reconsider this risk-benefit balance, and there's a valid option of continuing SGLT2 inhibitors, for instance, in patients with chronic kidney disease or in patients with heart failure, especially if they don't also have type 2 diabetes and have normal insulin sensitivities. And you could do this in an individual level, or you can make a local protocol differentiating patient populations and change this practice. This is what we do in the Amsterdam UMC, where a lot of patients are continued, and we would monitor for metabolic acidosis. We'd be more aware of acid-base problems, treat early, try to prevent this, but keep part of the population on their SGLT2 inhibitors to improve their perioperative health profile and risk of post-operative complications. Thank you very much. This was me, and have a good day.